Well, good afternoon, and thank you everyone for joining us today. We are focusing on the STI treatment guidelines for today's webinar. And just as a reminder, this is part of a series around sexual health with PIDS, and we are very excited to be ending the year covering the STI treatment guidelines. Next slide, please. Just for housekeeping today, you are generally all on mute during the webinar. And if you have any questions, there is a Q&A tab at the bottom. Please write your answers in there so that we can track them, and we will do our best to address questions at the end of the webinar. Next slide, please. The webinar today is also being recorded. We will post a link on our website in the next week or so. Free CME and CNE is also being offered. Instructions for that will be sent after today's webinar, and the deadline is January 13th. Next slide, please. I'd like to introduce today's speaker. It's Dr. Jason Zucker. Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. He is trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. Well, welcome, Dr. Zucker, and thank you for presenting today.
Sorry, I was on mute. Good morning, and thank you for having me today to talk about STI and the 2021 STI guideline update. You know, a lot of what we've done through these sessions over the past year and almost a year and a half now is really review different parts to the guidelines. What I want to do today is a case-based review. So a lot of what you're going to hear is going to overlap with what you've heard before, but these are going to be cases. And these are cases designed for the ID fellow. So many of them are actually inpatient cases where you get called as a consult for an STI question. So the goals for today are just to quickly review the sexually transmitted infections, describe some of the important updates to the 2021 STI treatment guidelines, and do it in a case-based format so you can really see how it applies to your patients, and then illustrate how to apply these guidelines to your practice. As a reminder that the CDC updated the guidelines in 2021, and that these guidelines are over 1,500 references and hundreds of pages long. So we're not going to cover all of them today, but everything that we do cover will be in here. All right, so today's structure is going to be a choose your own adventure. So we're going to put up a poll and we're going to let you pick the cases that you're most interested in. We may or may not get through all of the cases today. In fact, we most likely won't, but pick the cases that you think sound most interesting, and we're going to cover those cases today. Nice, and Gary, we'll give them enough time till almost everybody answers this first question.
That sounds good. And I know it takes a little bit to read each answer.
Of course. All right, let me take a screenshot of this. All right, Gary, you want to end the poll now? Amazing. So with almost 56% of people picking it, the 6-month-old with 1 month of cough, emesis, and diarrhea is number one. So we're going to start with that. Then we'll go to the 19-year-old with painful genital lesions. And then we'll do a few of the other cases that have over 20% of people choosing them. So our first case is our 6-month-old, full term with 1 month of cough, emesis, and diarrhea. So to give you more history, it's a 6-month-old full-term male with albinism who presented with 1 month of cough, emesis, and diarrhea. In the ED, the patient was febrile and ill-appearing with prolonged cap refill, started on IV fluids, ceftriaxone, and azithromycin. Initial labs had a CBC with 14% bands, but a CRP of less than 0.2. Abdominal ultrasound showed splenomegaly. The respiratory panel was negative for pertussis. Chest x-ray with bilateral patchy opacities, consistent with edema or atelectasis, and the patient was admitted for hypoxia. In terms of previous history, the pregnancy history was unremarkable. Patient had excellent prenatal care, and after birth, the patient and mother were doing well. At about 4 months of age, both mother and baby had unspecified viral infections and were seen in the ED a few days apart. The patients both returned to baseline within a few days. At about 5 months of age, the patient began having issues with feeding and was seen by neurology. In terms of social history, the patient lives with the mother and 4 siblings at home. The mother is from Mali and came to the US about 1 year ago. The father is from near Mali, came to the US in 1996 as well and works odd jobs. And there's no family history of HIV, TB, or other infectious etiologies known. So the hospital course was notable for progressively worsening hypoxia, resulting in eventual intubation. And so I'll put it out to the audience, and you guys can use the chat function. What type of testing would you recommend? Again, today's session is designed to be interactive. So what type of testing would you think about getting for this patient? Oh, chat is disabled. Shoot. Okay, feel free to put in the Q&A what type of testing you might think about for this patient. Remember, it's a 6-month-old presenting with hypoxia resulting in intubation. Any types of tests that you would think about? I see PCP on lower respiratory sputum. I see a chest x-ray, BAL for PCP, HIV PCP, HIV serology. Excellent. So let's give you a sense of what we did. So we did send a Fungitel or a beta-D-glucan that came back at greater than 500. The PCP PCR was positive. The LDH was 1600 and the RPP was negative. For those of you asking about HIV serology, the patient's HIV antibody antigen and confirmatory testing were positive for HIV. And the patient's immune workup showed a CD4 of 396. So do you think the patient has HIV? Yes or no? Do we have this as a question, Gary?
Yes, sorry, Jason, I was on mute, but yes,
Oh.
I just launched that poll.
So do you think this patient has HIV? So I put a lot of people in the question and answer suggesting HIV serology, which makes me think that they were looking for HIV. And it looks like almost everybody thinks that this patient does have HIV. So just as a reminder, because it is a pretty common call to infectious diseases, particularly from transplant and other services, it's really important to remember interpreting HIV results in the HIV testing algorithm. It starts with the screening test, which is most commonly the HIV-1/2 antigen antibody test. There's then a confirmatory test with an HIV-1/2 antibody differentiation assay, which is then followed, if negative, by an HIV-1 or HIV-2 NAT to make the final diagnosis. When we see false positive patients, we often see a positive antibody antigen with a negative genius, and then we have to wait for the RNA NAT to return to be able to make the final diagnosis. In this case, the patient's first 2 tests were positive, confirming the diagnosis of HIV. Just as follow-up, this patient was started on Bactrim and steroids for PCP, and other systemic antibiotics were discontinued. They were started on antiretroviral therapy with zidovudine, lopinavir, ritonavir, and lamivudine for presumed HIV. The HIV viral load returned greater than 10 million 1 week later, and mother and father would actually eventually go on to both test positive as well. So what happened in this case? Well, we had mother-to-child HIV transmission, which can actually be increased. We had mother-to-child HIV transmission. And one of the other things here is that mom actually tested negative for HIV during pregnancy. The suspicion is that mom actually acquired HIV post-pregnancy, as there's actually an increased risk of HIV acquisition, both during pregnancy and the period of time after pregnancy as well. In terms of mother-to-child transmission, this mom was negative at her 3rd trimester screening and at delivery. So what the suspicion is here is that this patient acquired HIV through breastfeeding, which can occur in up to 40% of patients, and one of the major ways that you can acquire it. And one of the reasons we counsel against breastfeeding in many in patients who are HIV positive. So that's it. Let's go back to our cases. Our next option that was chosen was the 19-year-old female with painful genital lesions. Whoa. Sorry, guys. I don't know what happened there. Our link did not work. Give me 1 sec. All right. Can you guys see my slides? Gary, can you see my slides?
Yes, Jason, I
Excellent.
can see them.
So this next case is a 19-year-old female who presented to the ED with severely painful genital lesions. They're so painful she's unable to put on her pants. On exam, they look like herpes, and she's admitted to the hospital for pain control. So the question is, what test should you send to diagnose HSV in this case? All right. So it looks like the majority of people chose HSV PCR from an unroofed lesion. Some people chose HSV viral culture, and some people chose HSV rectal PCR, and somebody chose HSV IgM and HSV IgG. So just as a reminder, in terms of diagnosis, the virologic test when lesions are present, so the detection should be done via PCR or viral culture. However, in the updated guidelines, PCR is the preferred diagnostic test. So the FDA cleared PCR tests are both sensitive and specific and can distinguish HSV1 and HSV2. Viral culture, on the other hand, has low sensitivity, especially for recurrent and healing lesions, but is the only way to detect acyclovir-resistant HSV. And so for patients where you're worried about resistance or you're worried about more complications, you might think about doing culture. Otherwise, it'll be PCR as the proper test. Just about serology. So for those who chose HSV, IgM, and IgG, serology is really hard to interpret. It's useful for atypical symptoms in individuals with negative HSV PCR or culture results. It's useful in people with a clinical diagnosis of herpes who've never had lab confirmation. It can be somewhat helpful 12 weeks after suspected recent acquisition. And it can be helpful if a patient's partner has HSV to provide appropriate counseling. It may be useful for people at higher risk of infection and for persons living with HIV, but it's not useful of screening of the general population. One other update in the 2021 STI guidelines is that they've recommended now 2-step serologic testing using an EIA assay, IgG, which can actually often be falsely positive if there's a low index value. They then recommend confirmatory testing with a second test that uses a different antigen, either the BioKit or Western blot. And as a reminder, IgM is never recommended for serologic testing. One caveat to this 2-step testing is it's incredibly challenging to do the second test. The Western blot is currently only available from the University of Washington lab. So that's the reference lab you have to use if you want to use the Western blot. And BioKit is not available at most commercial labs. I've heard it is available at one of the commercial labs right now, but there's only one commercial lab where you can run the BioKit. And so it can be frequently very challenging to be able to do this two-step testing for confirmation. So going back to our patient, she returned positive with an HSV PCR, her HSV PCR returned positive for HSV1. What would you like to start for treatment for her? All right, so in this poll, most people chose valacyclovir 1 gram 2 times a day. Some people chose acyclovir 3 times a day and famciclovir 3 times a day. And the truth is there's actually no right answer because these are all reasonable treatment options. These are all options that are in the guidelines. In general, most people prefer valacyclovir because it's twice a day, as opposed to something that's 3 times a day, making it slightly easier on the patient. But these are all considered appropriate treatment choices. In general, we do 7 to 10 days of treatment, although it can be extended if healing is incomplete after the 7 days of therapy. One of the other really great things in the guidelines are the HSV counseling messages. And if you haven't read them, I really advise you to go through the guidelines and read them carefully. I'll just give you some of the highlights for this particular patient here from the HSV1 section. So the first is that using serology, you can't tell if an HSV1 seropositive person is infected orally, genitally, or both. HSV1 is an increasing cause of genital herpes, especially in young women and men who have sex with men, just like in the patient we saw today. Genital HSV1 is associated with less frequent genital recurrences relative to HSV2. And genital HSV1 is associated with less frequent genital shedding relative to HSV2. However, asymptomatic shedding may occur, leading to transmission. Disclosure is recommended per expert opinion, and it's still unknown if it increases the risk of HIV acquisition. Depression has not been proven to prevent the transmission of HSV1, but you could consider suppression for frequently recurring lesions, whether they be oral or genital. There's also counseling available in here for asymptomatic HSV2, asymptomatic HSV2, and HSV1 genital herpes. That's out of order now. Okay. And so we'll go back to the cases. The third most frequently chosen case in our initial survey was case number 18-year-old. So an 18-year-old cisgender male with rash and elevated LFTs. Great. So this patient's an 18-year-old male who's been taking TDF-FTC for PrEP and presents to urgent care with a rash. On exam, the rash was diffuse, non-pruritic, non-painful, and made up of erythematous macules on his chest, back, palms, and soles. He had notable cervical and inguinal adenopathy, and his labs showed an abnormal BMP, or showed normal BMP-CBC, but elevated liver enzymes with an AST of 350 and an ALT of 450. A 4th generation HIV and monospot were negative. So it was discussed with oncology and decision made to admit for imaging and possible lymph node biopsy. However, overnight, a resident took a detailed history and found out that the patient was sexually active with his inconsistent condom usage and ordered an STI workup. The RPR was 1 to 256. Treponema antibody was positive, and 3-site gonorrhea chlamydia was negative. With that said, what is the next best step in management? All right. So I see that 2/3 of the people chose treat with long-acting PenG once weekly for 3 weeks. And then a couple of people chose 1 injection. And so actually the right answer is 1 injection. If you look, this was a patient who presented with a diffuse rash, cervical and inguinal adenopathy, and elevated liver enzymes. This is consistent with secondary syphilis. If you are reasonably confident that a patient has secondary syphilis, you do not need to treat them for latent syphilis or latent syphilis of unknown duration because it's not latent. This patient has active secondary syphilis, and so 1 injection is adequate. In terms of general screening for patients, these are the general recommendations for screening for syphilis. A couple of things of note is there's currently no national recommendations. Is that for men who have sex with men, they should be screened at least annually if sexually active, and every 3 to 6 months based on increased risk. For patients taking PrEP, they should be screened at initiation, and every 3 to 6 months based on increased risk. For persons living with HIV, pretty similarly. For non-pregnant women and non-MSM men, there's no national recommendation for routine screening, but the screenings at least annually is recommended in sexually active persons if increased risk. One thing that I like to tell everybody is that syphilis is on the rise and rising quickly. Currently, if you're testing a patient for STIs, you're screening a patient for STIs, you really should think about screening for HIV and syphilis as well. For pregnant women, due to the rise in congenital syphilis, which I know we'll talk about in a future one of these, the recommendations are the first prenatal encounter, plus the 3rd trimester and at delivery, if increased risk or in a community with increased prevalence. And I know most jurisdictions have moved to that increased screening. So going back to our patient and going back to syphilis, this is the diagram from the New York City STD Prevention Training Center and New York City Department of Health syphilis monograph. It outlines the stages of syphilis really well and is available on our website. So the first thing to note that's really important is to know that the incubation period of syphilis is really long. The incubation period is 9 to 90 days, meaning that individuals who are exposed to syphilis may not test positive or show symptoms for up to 90 days. That's one of the reasons we always recommend treating individuals who are exposed to syphilis, because you don't want to have to wait up to 90 days to make the diagnosis. Primary syphilis is identified by local symptoms. This is traditionally the painless chancre at the site of inoculation that we think of as typical for syphilis. It is important to note that the updated STI guidelines do highlight that primary syphilis can present atypically with either painful lesions or multiple lesions. I also want to highlight the fact that these are painless lesions, which means if they're not in an easily visible spot, like the rectum, vagina, or oral cavity, they may not be noticed. I always tell a story of we went to do a throat swab for a patient for just routine gonorrhea chlamydia screening, and we found a painless chancre on the tonsil that the patient would have never known is there if we didn't see it. Secondary syphilis is disseminated and has symptoms. This is what we usually think about the rashes on the palms and soles, or other disseminated symptoms like fevers, lymphadenopathy, hepatitis, and other things. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document a non-reactive or lower titer syphilis serology within the past year, or a patient of history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or latent of unknown duration. And these designations are important because they really determine what is and is not adequate treatment for syphilis. One other thing I don't want to forget to highlight is that we're seeing more and more early neuro, early ocular, and early otic syphilis. These things that we used to think of as late manifestations can occur during any stage. And as we're seeing more cases of syphilis, we're just numerically seeing more cases of early neuro, ocular, and otic syphilis. And so it is really important to screen patients who present with syphilis for signs and symptoms of these etiologies as well, or these syndromes as well. And so in treating syphilis, we treat by stage. This is the standard treatment guideline for treating syphilis, both within and not within pregnancy. And the first thing I want you to notice is that it hasn't changed from prior iterations of the guidelines. For incubation, primary, secondary, and early latent syphilis, it's 1 dose of penicillin G. The alternative treatment is doxycycline 100 milligrams twice daily for 14 days. And as a reminder, alternative treatment is not available for pregnant women. For late latent and late of unknown duration, it's intramuscular PenG 3 times 3 times once a week for 3 weeks. Sorry, once a week for 3 weeks. The alternative there is, again, doxycycline, 100 milligrams twice daily for 28 days, with a reminder that you can't use doxycycline in pregnant women. For neuroocular or otic syphilis, as well as tertiary syphilis, the recommendation is IV penicillin for 10 to 14 days. There is no doxycycline alternative. The alternative here is intramuscular Pen-G daily plus probenecid for 10 to 14 days. I will say that while I thought many patients would not be enthusiastic about the option of IM penicillin, I'll tell you that at the University of Washington Sexual Health Clinics, they actually do this standard for patients with neurosyphilis, and patients apparently are very positive about it, including coming in on the weekends to get their injections when the clinic is closed. Interpreting titers are important because it's how we understand whether we've treated people effectively or not. Quantitative testing involves serial dilution of serum specimens to determine the amount of antibody present. These non-treponema titers that are quantitative are used to follow treatment response and look for reinfection. So a 1 dilution change or a 2-fold increase or decrease in titers is considered not necessarily significant, while a 2 dilution change or a 4-fold increase or decrease in titers is indicative of adequate treatment if it goes down, or reinfection if it goes up. We'll go back to the cases now, but if you have any questions, please feel free to use the question and answer section for questions as well. Our next most requested case was, let's see here, a 21-year-old cisgender male with a rash. Well, that's weird. Oh, there we go. Sorry, I don't know why some of them are out of order. I apologize, but let's look at this case. So this is a 21-year-old cisgender male. He's living with well-controlled HIV. He's sexually active with men and notices some mild eye irritation and thought it was allergies. 3 days later, he felt warm with a Tmax of 100.7. He had worsening eye redness and drainage, and he was concerned it could have been from bodily fluids that got in his eyes during a recent sexual encounter. That partner actually tested positive for gonorrhea and chlamydia. He went to the emergency department, and this is what his eye looked like. In the emergency department, they did a workup that included genitourinary gonorrhea chlamydia test, RPR, HIV with viral load, CD4 count of 282. He received empiric treatment with ceftriaxone and doxycycline, as well as cipro-ophthalmic drops in consultation with ophthalmology, who recommended discharge and follow-up in 2 days. His testing was pretty much all negative. His RPR was 1 to 4, down from 1 to 32 previously. His HIV viral load remained undetectable. His CD4 was 282, down from 543, thought to be attributable to his active infection. And so he was seen in ophthalmology clinic, where they actually noticed these pustular lesions along the lower lid margins. They did a gonorrhea chlamydia swab of the eye, which was negative, and a bacterial culture swab of the eye, which was negative. They continued him on antibiotic eye drops. He came back in to see me later that day. At that time, when he came to see me, he complained of the eye pain, but eye pain. Sorry, 1 second. Also reported lesions on his left wrist, left forearm, left shoulder, and scrotum. On exam, he had different stages of these lesions with a pustule, a macule, and an ulcerated lesion. On history, he reported 4 sexual partners in the past month, all well known to him. None had traveled to Europe, none had unusual lesions, and the one had gonorrhea chlamydia that we knew about. I did some additional testing, including HSV VZV swabs that were negative, bacterial culture that was negative, gonorrhea chlamydia of the throat, which was positive for gonorrhea. Again, highlighting the importance of doing complete extragenital testing because in the ER, he only had genital urinary testing, and this would have been missed. Rectal gonorrhea chlamydia was negative. A respiratory panel was positive for rhinoenteral. I retreated him with ceftriaxone and doxy because the throat swab was still positive for gonorrhea, and discharged him with close follow-up. About 5 days later, he was seen in the opto clinic. He had worsening eye symptoms with swelling, erythema, and blurry vision. He had an increased number of skin lesions on the extremities, genitals, and feet, and the eye exam continued to show lesions along the lower lid margin. This is what his wrist and forearm lesion looked like, and this is what his face lesion looked like. And he had these 2 lesions on his back. Let's use the Q&A or the chat function. Let's talk about what's our differential diagnosis. So I see one person in the chat wrote Mpox. Another person wrote monkeypox. See a lot of Mpox here. So I'll say that on our differential, Mpox was definitely on the differential, as well as things like HSV, which is why we did the swab and we did repeat it at a follow-up visit, as well as disseminated gonorrhea and other etiologies. At this point, though, we were very worried about Mpox, and so we did bring him in for Mpox testing, and the testing did return positive. I'm not going to spend as much time on Mpox as I normally do, but just briefly as a reminder that Mpox is an orthopox virus, meaning it's in the smallpox family. In terms of this current outbreak, the current outbreak, which has decreased dramatically in the United States of late, was primarily through human-to-human transmission, through direct contact with body fluids or lesions, most prominently. Contaminated fomites and exposure to respiratory secretions were possible, but much less common. What's important as cases go down is that we have more awareness than ever to make sure that we don't miss cases, so we can continue to make sure we get to 0 cases of Mpox. Knowing that, we need to know how it how it presents. And in many cases, patients present with a prodrome of fevers, chills, headache, malaise, myalgias, and lymphadenopathy. Oh, and the rash with firm, deep-seated, well-circumscribed, sometimes umbilicated lesions that start on the face and spread to the extremities, including the palms and soles, that progress through several synchronized stages, can be painful and last up to 4 weeks. In this outbreak, it's important to remember that the prodrome may or may not be present. It was present in our patient, and that the rash is really very different. The rash is often starting in the genital areas and may not involve the face or extremities. The lesions are frequently in different stages, which was seen in our patient. And the presenting symptom may actually be proctitis or other things that would be easily confused with STIs. In fact, Mpox is very similar to many STIs. In terms of genital ulcer diseases, things like HSV, syphilis, chancre, and LGV look similar. Diffuse rashes, syphilis, VZV, HSV, molluscum, disseminated gonococcal infection can all look similar. And proctitis, gonorrhea, chlamydia, HSV, and even syphilis can be confused. And so when you look at these similar presentations, you understand why Mpox is talked about in an STI talk, because it would be very easy to miss Mpox in a patient presenting with symptoms similar to an STI. And so with that, we'll end our Mpox section and we'll go on to our next case. Did that one. So the next one's a 16-year-old cisgender female with dysuria and sepsis. So this is a 16-year-old female who came to the ED with dysuria. In the ED, she was found to be febrile and have a low blood pressure and a high white blood cell count. Her labs, where blood culture was done, a urine pregnancy test was positive. Her UA showed greater than 100 WBC, so it was reflex to culture, and urine, gonorrhea, chlamydia, and NAT were sent. She was started on ceftriaxone and admitted to the general inpatient service. So her blood culture was no growth to date at 24 hours. Her UA reflex to culture. and her urine culture came back with greater than 100,000 E. coli. However, her urine gonorrhea chlamydia testing also came back positive for chlamydia. So what is the best treatment for her positive chlamydia test? All right, so it looks like 2/3 chose doxycycline and about 1/3 or 40% chose azithromycin. I want to highlight one thing. Remember that she tested positive. Her urine pregnancy test was positive. And so our uncomplicated chlamydia treatment, the preferred agent is now doxycycline 100 milligrams twice daily for 7 days. But that's not the preferred agent in pregnant women. The preferred agent in pregnant women remains azithromycin, which is the alternative agent for everybody else. Again, 1 gram orally once, or quinolones 500 milligrams times 7 days, which we don't usually use in pregnancy anyway. And so for pregnancy, we really have to choose azithromycin. Now, one of the things I will talk about is why we switched from azithromycin to doxycycline as the preferred agent. Obviously, it's a lot more confusing because it's easy to miss things like patients are pregnant, and we need to be able to treat them with azithro instead. So the first reason to make this change was genital urinary infection. Actually had higher microbiologic failure. So this randomized controlled trial done by Will Geisler looked at adolescents in youth correctional facilities receiving directly observed therapy. They had 567 participants enrolled, and the efficacy of doxy was 100%. The efficacy of azithro was 97%, and the non-inferiority of azithromycin was not established. Said more clearly, azithromycin may not be non-inferior to doxycycline, or doxycycline may be better than azithromycin. However, this is such a small difference that I really doubt this would have changed the guidelines on its own. What really changed the guidelines was that for rectal infection, doxycycline was found to be superior to azithromycin with a 20 to 26% difference. And this is one of the randomized controlled trials. This is the one done in the United States that looked at 177 participants and found that doxycycline was significantly more effective than a single dose of azithromycin. Doxy is the blue line going up, while azithro is the orange line going down. And this was also found again in a Australian study that again found that 7-day course of doxy was significantly more effective than a single dose of azithro. So that's great for rectal chlamydia. But do we need to worry about it in women? And the answer is yes. Rectal infection is not uncommon among women with genital urinary infection, with 33 to 83% infected, regardless of behavioral risk factors. And when they actually looked at different populations, they found that women with urogenital chlamydia, about 77% had rectal chlamydia. Women reporting anal sex, about 10% did. Women at high risk, 26% did. And even women attending routine clinics, 6% did. So it's things like this that really drove the change to doxycycline. Because when you're choosing a treatment for chlamydia, you're really trying to balance the efficacy of doxycycline versus the ease of azithromycin. Some things to keep in mind: access is one difference. Many clinics and emergency departments may be unable to provide a 7-day course of doxy, while many can provide a single dose of azithromycin. Patients who are uninsured may only be able to obtain what they can get in clinic or the ED. And this challenge is actually magnified for our pediatric and adolescent patients. For example, in one study in DC, they found that only 58% of adolescents who received a prescription for an STI in the ED filled it. Adherence is a second difference. It's obviously easier to take 1 gram once than it is a medication for 7 days. However, one thing that's really important is setting our judgments aside. When the gonorrhea update came out, there was a lot of concern about 7 days versus 1 dose. But I do find that most patients, even adolescent patients, can do it, and frequently the ones that can't tell you. Additionally, in the recent randomized controlled trials, azithromycin performed so poorly that even in the context of imperfect adherence, doxy may actually be better than azithromycin. Finally, is confidentiality. Patients may value not having pills in the house. They may not want a parent or friend or roommate to find out, and be able to treat them at the point of care may be beneficial. So some reasons you might want to choose azithromycin. The first and the biggest is pregnancy or may be pregnant, as was in our case. Patients with a history of allergy or intolerance to doxycycline. Patients unlikely to be adherent. And patients unlikely to be able to obtain doxy and azithro is available at the point of care. This is our recommended approach. So for patients with suspected chlamydia, if they're possibly pregnant, the answer is azithromycin. If it's a possibility of rectal chlamydia, they really should get doxycycline. And otherwise, shared decision-making with doxycycline preferred. Just to highlight follow-up, as a reminder, all patients who test positive for chlamydia should abstain from sex until partners have completed treatment or 7 days after single-dose therapy. Consider repeat testing at 4 weeks for rectal chlamydia, treated with azithromycin due to lower efficacy. There's a test of cure at 4 weeks if pregnant, and rescreen at 3 months for reinfection. Our next most common choice, we're getting down a little further here, with 25% is the 18-year-old cisgender male with rectal pain. We'll skip that one for now and come back to that in a second. The 16-year-old with abdominal pain and cervical motion tenderness. So in this case, we have a 16-year-old cisgender female who came to the ED with severe abdominal pain. Her exam is notable for diffuse abdominal pain and pelvic pain with cervical motion tenderness. Her labs are notable for leukocytosis, and GYN recommended admission for pelvic inflammatory disease with STI testing pending. So what would you plan to start for her moderate to severe pelvic inflammatory disease? And these are long choices, so I'll give you guys an extra minute. All right, so let's see. It looks like about 70% said ceftriaxone plus doxy plus metronidazole, and 25% said ceftriaxone plus doxy plus metronidazole. So it looks like we have 500 versus 1 gram of ceftriaxone, and then ceftriaxone plus doxy. So if you are going IV, the recommendation is 1 gram of ceftriaxone, along with doxycycline and metronidazole. One of the other changes to the STI guidelines in 2021 is that metronidazole is now added routinely. A lot of people are surprised to hear that because we often added it routinely anyway. However, the previous recommendations where you could do it with or without metronidazole, and many patients or many providers wouldn't give metronidazole to make it easier on patients. But in the last period of time, there has been an updated randomized controlled trial that compared with and without metronidazole. It was a double-blind placebo-controlled trial of 233 women. And they found that symptom improvement 3 days in presence of anaerobic organism, the endometrium, were the outcomes. And they found that at 30 days post-treatment, individuals who received metronidazole had lower endometrial anaerobes, less pelvic tenderness, and decreased cervical MGen, which was a little surprising, with similar rates of adverse events. And so based on those findings, particularly the decreased pelvic tenderness, the recommendation was to add metronidazole routinely. Just in terms of a beta-lactam allergy, the options are levo plus metro, moxie and metro, and zithro and metro. One other really important thing to note is that, previously we had told people to abstain from alcohol after metronidazole or tinidazole, and that's actually not needed. It turns out that prior studies were based on animal studies and case histories, and metronidazole does not inhibit acetaldehyde dehydrogenase like does sulfram. I'll go back to the cases, and again, if anyone has any questions, please feel free to put them in the Q&A or the chat. We'll do our last case now, which is the 18-year-old cisgender male with rectal pain. So Jordan is an 18-year-old male who's been on PrEP for the past 3 years through a school-based health center. In March, during the COVID outbreak, he went to urgent care with rectal pain after recent exposure to a partner with syphilis. His RPR was negative, and he did not receive treatment, but was advised to follow up at his PM date. Could his rectal pain be syphilis? Sorry, guys, don't worry about the lumbar puncture question. I apologize for that. That's a question that's going to come later in this one. So it looks like everybody agrees that this could be syphilis, and that's exactly correct. The classic presentation with the single painless ulcer or chancre at the site of infection. But as I mentioned earlier, we're seeing more of these atypical presentations with multiple atypical or painful lesions at the site of infection, most prominently in the rectum, like in this case. It's a great reminder that this was a patient who was exposed to syphilis, was tested and was negative, but we all know that there's a very long incubation period. So he probably really should have been treated after his exposure. So 1 month later, he felt like he was having a hard time hearing the TV. He went to the ED where he was seen by ENT. He was diagnosed with asymmetric hearing loss, and an MRI was recommended. The MRI was unremarkable, and he was told to follow up outpatient. 2 months later, he felt like he was having a hard time seeing the TV. He went to the ED where he was seen by ophtho. He was diagnosed with panuveitis, and they recommended sending a panuveitis workup, and he was told to follow up outpatient. As part of that panuveitis workup, his RPR returned 1 to 128, and he was called by the DOH and advised to go to the emergency department. As a reminder, in our case of syphilis pathway here, he's presenting with signs of early ocular and early otic syphilis. One of the things that they did in the updated guidelines was really give an enhanced clinical description of ocular and otic manifestations of syphilis. Ocular syphilis often presents as panuveitis. It can involve any structure in the anterior and posterior segment of the eye, including conjunctivitis with red eye and pain, anterior uveitis, posterior interstitial keratitis, optic neuropathy, retinal vasculitis, and can lead to permanent vision loss. Otosyphilis typically presents with cochleovestibular symptoms like tinnitus, vertigo, central neuric hearing loss that can be either unilateral or bilateral, have a sudden onset, and progress rapidly. It can also result in permanent hearing loss. I hope you notice that these are both emergencies because the vision and hearing loss can be permanent. There's this tool from Kings County for routine screening that I recommend all clinics download and ask your patients with syphilis. It's a really helpful guide to rule out oto, ocular, and neurosyphilis in patients who have syphilis and determine if additional evaluation from either ENT or ophtho is warranted. This is where the lumbar puncture question came in. Obviously, people couldn't answer that before due to the not having all the information yet. But the answer in this case is he does not need a lumbar puncture. So he was admitted. For early neuro and early ocular syphilis, it's not going to change your management whether or not you do a lumbar puncture. They're all going to get IV penicillin. This is a change from previous iterations of the guidelines, where they did recommend that if the initial lumbar puncture was abnormal, you should repeat the lumbar puncture. Now they just recommend following the RPR. And since there's no need to repeat the lumbar puncture, you don't need to do a lumbar puncture up front if it's not going to change your treatment management. So he was started on IV penicillin and discharged with a PIC. All symptoms resolved, although he may have some residual hearing loss. And just to wrap up his case, syphilis can present atypically with multiple or painful lesions, have a high suspicion for neuroocular and otic syphilis. Think about screening routinely with the Kings County tool in your clinic. We're doing fewer lumbar punctures. It's not routinely needed for isolated ocular otic symptoms or for follow-up as long as RPR improves. No repeat CF exam at 6 months with adequate RPR response. And just to cover a couple of the things we went over today, the 2020 STI guidelines really emphasize extragenital gonorrhea chlamydia testing. They did that because it does affect management, as we talked a little bit about earlier. Think about Mycoplasma genitalium for persistent dysuria. We didn't get to that case today, but that's always an important thing to think about. For syphilis, no LP with ocular or otosyphilis. Make sure that all mothers and babies are screened for syphilis. And consider Mpox an emerging disease that's transmitting like an STI. In terms of treatment, the gonorrhea guidelines have increased the dose of ceftriaxone to 500 milligrams. For chlamydia, doxycycline 100 milligrams twice daily is preferred in non-pregnant patients. For Mycoplasma genitalium resistance-directed sequential treatment, doxy followed by moxy. And for pelvic inflammatory disease, we add metronidazole routinely. For prevention, HIV prevention has been emphasized. And as a reminder, we should be informing all sexually active adults and adolescents about PrEP. If you want to learn more, we have the National STD curriculum. If you ever have a challenging question, we have the National Consult line, stdccn.org. And I've hopefully left a few minutes for questions in case people have any additional questions. And thank you very much for joining our cases today.
Thank you so much, Dr. Zucker. Just a reminder, if you have a question, please type them in the Q&A box. And we will be having another session as part of this series. It will be on January 10th, and it will focus on congenital syphilis. I believe you should receive an electronic flyer about this, and we hope to see some of you there. Dr. Zucker, we do have one question.
Yep.
Are there considerations to not do an LP in congenital syphilis if the RPR falls appropriately?
That is a hard question. I don't know if there's a consideration to not do the LP in congenital syphilis, to be honest with you. I think it's a good question because we are going to give all of these patients, many of these patients that we suspect congenital syphilis, IV therapy. And so it is a good question. I don't know if we have enough data yet, but we can look into whether or not people are discussing that option.
Great, thank you. I don't see any other questions right now. We can give it another minute or so if there are questions. We will be sending out the slides from today as well as CE instructions to everybody. After the webinar, you should receive this via email.
Howard, do we want to remind everybody about submitting cases? So all the cases that Dr. Zucker presented today were cases, many of them were seen at our institution by our fellows. And it would be super great if you all have cases that you would like to submit. We would like to have you present to the group in May.
Thanks, Natalie. And yeah, so we actually have not sent that out yet. We'll be sending that out in the new year, but we will have some detailed instructions on how to submit, what we'd love to see. And the idea is in May, we will be holding a session where you can present your cases and we will have a panel discuss the cases and go through them. So thanks, Natalie, for that reminder. Jason, I don't see any other questions right now. So if you're okay with it, I think we can end today's webinar, but would really like to thank you for your time and providing such an innovative presentation. Thank you.
Thanks, everybody.